Hey everyone, thanks for joining Baltimore County Fire Department EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU physician at Hopkins. I'm an active volunteer at Pikesville Volunteer Fire Company, and I have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of Baltimore County Fire Department and Dr. Andy Pollack in the EMS office, thank you. On behalf of the EMS office director, Shannon, Captain Stewart, Captain Natz, thanks for what you guys do. And thanks for your dedication to lifelong learning. A big shout out to Ashley Brooks, who is helping us run our live stream. Ashley is also the one who is going to be sending out a link in the chat at some point during this training. If you click on that link and give us a little bit of information, we can get you your MIMS CEUs. So if you want your MIMS CEUs, keep an eye out on the chat. And we also will announce it. Ashley Brooks will send out a link to help us sign in. This has to be resolved. If you're having any concerns about signing in and getting your CEUs, please reach out to Ashley or I in the chat. We need to resolve these before the end of the training to get you the CEUs for participating. So tonight we have Dr. Matt Levy. Dr. Levy is the medical director for MIMS Region 3. He is also the medical director for Howard County Department of Fire and Rescue Services. He's the Associate Medical Director for Baltimore County Fire Department and Associate Medical Director for the Johns Hopkins Lifeline Critical Care Transport Program. Dr. Levy's career in emergency medicine spans over 25 years and began as an EMS provider. He's an associate professor and holds a leadership role in the Division of Special Operations at the Department of Emergency Medicine, Johns Hopkins University School of Medicine. He completed residency and was chief resident at Johns Hopkins. Dr. Levy maintains an active role in a variety of local, state, and federal and international elements related to emergency medical, tactical, and disaster care. Dr. Levy, thanks for being with us tonight and sharing your wisdom and expertise.
Thank you, Dr. Barinholtz. Good evening, everybody. Hope you can hear me okay. I'm going to just take the screen here if I can and try to get my slides to load here. So bear with me a second as we do that. And it's wonderful to be with everybody. I hope you all are safe and well and warm tonight. Can you guys see my screen okay?
Looks good.
Okay, great. So it's great to spend some time with everyone and to share a topic that I think is really important and we'll talk about for a number of different reasons. But this is a neat example of an innovation in hang on a second here, guys. Let me fix something on my slides here. Okay, let's try it that way. End-Tidal CO2 monitoring is one of those things where is actually we are changing practice in the ED with what we're doing based upon what we're doing in the field. So it's a really cool thing. So I'm going to guess that most people here are tuning in to learn a little bit about capnography and End-Tidal CO2 monitoring. The advances that we've made in the ability to monitor our patients over the past decade and a half are really substantial. And this is something that, you know, when I was a box riding EMT and medic in the 90s, we didn't have this at our disposal. And when it came online, people were not really sure how to use it and what to do with it. And I think for those of us who've been doing this a little while, there's still a little bit of that. But I really think that an appreciation for how valuable and important capnography can be will really help your practice. Above all, it'll help your patients and it'll help us do good patient care. So let's jump right into it. We're going to talk a little bit about what capnography is. And in order to do that, we really need to discuss the physiology of breathing and of respiration. Now, I'm not gonna be too painful about this, but there are some fundamental concepts that we all know that I want to apply to this discussion that'll hopefully help you realize why and how this stuff is so important. Along those lines, we're going to go over a little bit about the normal and abnormal end-tidal CO2 values that you may encounter, you may see, and we'll go over pretty much the four major pre-hospital applications of end-tidal CO2 monitoring. Now, I should warn you that I actually like to do audience participation. That's a little hard to do sometimes via Zoom. So if you have a question or you have a comment, I may ask Dr. Barinholtz to help me monitor the chat screen because I actually can't see it from my, let's see if I can see it here. Okay, looks like maybe now I can see it. But if you have a question or a comment, please put it in the chat box. And I don't know if you'll be able to come off mute, but certainly feel free to come off mute. If something comes up along the way, please feel free to interrupt and ask. So that said, let's get right into it. So why capnography? It's not just another cool thing we can do. Sometimes we find ourselves in EMS doing things because we can, right? So we do a lot of things because we can, because we have the technology. We might as well use it. We have it, that kind of thing. Capnography is one of those monitoring technologies that really does have a direct effect on patient care. Right? It is allowing us in real time to monitor both monitor and in our case measure the flow of exhaled gases, specifically carbon dioxide from a patient. Why is that important? Well, I think we all remember from way back when that carbon dioxide is what we breathe out. It's the product of cellular metabolism. And so if our cells are working, if they're churning and burning and doing their job, and we should be making CO2 as an end product of metabolism. So it's one of the many ways we can monitor how well the body system is performing. And certainly in times of a critically ill or injured patient, it tells us a whole lot about what is or isn't working. There are some real practical boots on the ground. What does this mean for me at 3 a.m. stuff that's worthy of talking about? First of all, it allows us instant and ongoing confirmation of an advanced airway, right? So it allows for us to know with certainty, well, I will say with near certainty, that we have an airway established and maintaining. We can use that to also help guide our resuscitation efforts, including our ventilation efforts. I'm going to venture to say that from our BLS colleagues online tonight, you may have ventilated a person who's intubated with end-tidal CO2, and someone may have said to you, if this number goes up, I want you to squeeze faster. If it goes down, squeeze slower. And we'll talk about why that is tonight. We'll talk about how that means. And if you have no idea what I'm talking about, that's okay too. We'll by the end of this talk, I promise you will. Above all, it not only helps guide these resuscitation efforts, but it helps really give us an insight as to where we need to focus our priorities for the management of this patient. Now, there's a quote here, and I want you to note the quote is from 2005, but it typically takes us about a decade in medicine to go from studies and research and in science that's been groundbreaking to broad implementation. Fewer things happen much faster than that, but they can. But that decade-long comet tail is fairly typical in innovations. So in this quote, the authors noted that there were no unrecognized intubations, okay, that were found in patients for whom paramedics were using end-tidal CO2 monitoring after they intubated. Whereas the failure to use end-tidal CO2 monitoring was associated with a 23% missed intubation rate. Why does that matter? Well, intubation, the clinical skill of putting an endotracheal or a breathing tube into the trachea, as you guys know, that's one of those things that is a very high-risk procedure. Hand in hand with it being so high risk is the fact that sometimes that tube doesn't go where we want it. Sometimes, despite all efforts, that tube may end up initially in the trachea, but you hit a bump, something happens, and the tube comes out. And we've seen this happen. The tube landing in the esophagus into the food pipe, if you will, is a known complication. That can happen. And there isn't an intubator in the world who would disagree with that. It's a complication, but it cannot go unrecognized. And when it goes unrecognized, that person dies. So esophageal intubation is a known complication of intubation, but the unrecognized esophageal intubation is something we can have zero tolerance for in EMS medicine. And when it happens, we have to immediately fix it because we know that at that point, we're not getting oxygen to the brain, to the heart, and circulating throughout the body. So technology such as capnography is incredibly important. So if you're not using capnography routinely, on your intubated patients, I hope after tonight's talk, I will convince you as to why you should be doing it. And oh, by the way, you can also use it on your patients that you're bag valve mask ventilating as well, and on patients that you're monitoring through nasal cannula as well. So we'll cover all this stuff in a second. All right, let's talk a little bit about what a normal waveform looks like for just a second. All right, and what I want you to note is this type of waveform here, okay, is very, very concerning. All right, this waveform here, particularly in someone that started off with a good solid waveform, we have to assume there's no air exchange. So no waveform equals no air exchange equals they're not breathing. And so again, capnography has emerged as the gold standard to not only confirm, but monitor ongoing tube placement. All right, so let's talk a little bit about some of the physiology here, just quickly, guys. So bear with me a second. All right, so respiration, ventilation, oxygenation are all terms that get mixed up and jumbled up and used contextually, sometimes correctly, sometimes incorrectly. Let's start off with respiration. So respiration, the act of respiration, is a cellular process. All right, that's where oxygen is taken in, a metabolic process occurs, and the output of that metabolic process is carbon dioxide, and that is released. Respiration occurs at the cellular level. Okay, ventilation is the mechanical process of moving air between the lungs and the atmosphere so that oxygen can be exchanged for CO2. And you may remember that occurs at the alveoli level, those microscopic little sacs of air or little balloons that are inside the lungs. That's where that occurs. And of course, oxygenation is the act of getting the oxygen into the body, specifically into the bloodstream. So each one of these things has a different piece of a very important puzzle, but the whole system doesn't work if you take one of them out of it. So when we think about it this way, we breathe in, and as we're breathing there, we're breathing in oxygen, and we're breathing in oxygen and other things in the gas, but most of what we're breathing in an atmospheric gas is oxygen. Okay. And we bring that in, that oxygen goes in, it gets, hopefully our lungs are working and our airways are working, and it gets down to the level of the alveoli. And when it does get to the level of the alveoli, it gets into a capillary, and that capillary, it allows for that one oxygen molecule, okay, that one size, to go in one end, to get perfused through the tissue throughout the body where the work occurs of cellular metabolism. And that work, that oxygen, then gets converted to energy, and a metabolic process occurs, and that's where oxygen and glucose are mixed together. Energy is created, and CO2, carbon dioxide, is then released and circulated back through the veins into the lungs and then back out to the atmosphere. So when we think about this is the waveform that you will see for End-Tidal CO2 monitoring. This is the representation of a rise in CO2 with exhalation, okay, followed by a sudden drop in CO2 with inspiration. Now, there are a couple more technical terms to go over. The capnogram itself is the waveform, is the actual visual representation that you're seeing on the graph. Okay, this is an actual measurement of the amount of exhaled carbon dioxide. The capnograph is that number that's next to it. Now, both these the number and the waveform together provide us a tremendous amount of information. And that's what we're going to really talk about here. Normal End-Tidal CO2 range should be between 35 to 45. So if I were to put an End-Tidal CO2 sensor on your mouth or on your nose, because we can do it either way. We have a nasal cannula apparatus that can do this. And under normal physiologic circumstances, people are going to exhale with a CO2 range between 35 and 45. And that means something, okay? It is ultimately a window into the ventilatory status. Now, a moment ago, I shared with you that both the number and the waveform mean something. And on this slide, you can see that the number of 50 is the same on both of those, but there's two very different things going on here. And those two very different things are a window into what's going on inside this person's body. So as we walk through this, let's try to expand upon this just a little bit more. Increases in End-Tidal CO2 occur in response to increased muscular or metabolic activity. All right. Interestingly enough, after we intubate somebody during a cardiac arrest, if we see a sudden rise in End-Tidal CO2, then that may be an indicator that person, or that is a reliable indicator that person may actually have return of of spontaneous circulation. In addition, other things where we tend to see increases in End-Tidal CO2, well, if we're effectively bronchodilating someone, a severe asthmatic, or someone in severe COPD exacerbation, if we bronchodilate them, we can then help them offload that CO2. Remember that with a disease such as asthma, the CO2 levels are something these people retain CO2. So those high levels could also be an indication that they are hypoventilating, that they are not adequately breathing or not adequately able to off gas or offload that CO2. Whereas decreases in end-tidal CO2, they may indicate that there's a decreased muscular activity or decreased perfusion. They can also indicate hyperventilation or bronchospasm. So if I go back to the slide here for a second, you can see in the top graph, this person's breathing, and each one of those square waveforms or rectangular waveforms represents an exhalation cycle followed by an inspiration. So that the top one, that person is hypoventilating, and the bottom one, that person is hyperventilating, yet the number is the same. So in this case, those numbers mean two different things. So that number up top, that person, that waveform up top means that they're breathing too slow and they're retaining that CO2. Whereas the number on the bottom, they're breathing fast, and despite breathing that fast, they are still having a CO2 that's elevated. It may indicate something more metabolic is going on. Let's move on here. So again, in a normal end-tidal CO2, we see that very sharp upward plateau, reading this from left to right, followed by that flat line. Sometimes you see that line there. It has a little bit of an upward slope because as you're exhaling, you're blowing out with slightly more effort towards the end of the breath, and then that quick drop down as someone takes a breath in. That's the normal end-tidal CO2 waveform. That's what you really want to see on the monitor. That's what you hope to see. That's what every paramedic, when they put that end-tidal CO2 monitor on, and every emergency physician, when we do this after we intubate somebody, that's what we're looking for. And then we take a breath ourselves when we see that, because we know, okay, we're actually oxygenating and ventilating this person. All right, so as we break this apart here, the CO2 is going up as time goes by. So again, here, a normal waveform. We're going to break this down. A to B is the end of inspiration, as someone is taking that deep breath in all the way, and at point B, that's where their breath in stops, and then B to C, okay, is the beginning of exhalation. C to D is what we call the alveolar plateau, and that abruptly ends at the end of the exhalation phase. And from D, moving back down to E, that's where the new breath begins, and then you're back to that end cycle. So there are a couple of common waveforms I'd like to go over, and then we're going to open this up for some discussion here. So we talk about common waveforms. This again is what we hope to see in a normal waveform, and you can see some other information here that's very helpful. You can see the rate of respirations being 16. You can see the end-tidal number of 39, and we know that that those numbers there are all normal parameters, normal ranges, and that's really reassuring for us to see. So when we see numbers like this, that indicates to us that person is physiologically, at least we know they're able to ventilate. Now, keep in mind, guys, that this does not say anything at all about their ability to oxygenate. Okay, so there are conditions where people can have completely normal end-tidal CO2 waveforms and normal respiratory rates and still not being able to oxygenate. And so this is one piece of an important puzzle, but we couple this with a pulse ox, a normal pulse ox, and we feel very confident that we're able to actually perfuse this person down to a cellular level. If not, we have to wonder what else is going on. In a condition such as hypoventilation, such as the top condition here, we can see this person has a respiratory rate of 8 and an end-tidal CO2 of 48. And we can see this very long, very slow respiratory pattern. Can anybody think, and I'm going to ask you guys to come off mute or to put your comments in the chat box, can anybody think of a commonly encountered condition that we may see in our pre-hospital practice where someone's end-tidal CO2 might look like this? Okay, Matt Byers says overdose. Bob says overdose. Yep, a lot of overdose. Yep, specifically any type of overdose where there's CNS depression. That's right. Sam says opioid or benzo overdose. You guys got it, right? So anytime there's profound CNS depression, we may see a waveform that looks like this. And in these waveforms, the person is able to exhale okay, but they are breathing at a very slow rate, and they're also retaining that CO2. And in fact, the higher the CO2 level goes, in some cases, the slower they're going to breathe because of the CO2. CO2 is actually a sedative in and amongst itself. So that hypercapnia can be really bad. There are a number of other conditions that we think about something like this, but certainly take a different picture. Take someone who's in respiratory distress, who's an asthmatic, who was breathing fast, and now you put them on the monitor and they're starting to do this. In an asthmatic situation, that's a person who's going to crump on you and going to crash on you. We'll talk a little bit more about that we'll talk about that a little bit later on and things I want you to do to be ready. Now let's look at the bottom scenario here. In this case, we have someone who's breathing super fast, 35 times a minute, and they're breathing at a rate of 20, with an end-tidal CO2 of 24. So they're blowing off their CO2. Now, this is physiologic hyperventilation. But there may be situations where someone is doing this for a particular reason. And I don't mean volitionally, guys. I don't mean intentionally, but they're doing this because their body is trying to compensate for something. So can somebody think of a condition where someone might be, maybe you're called for a medical emergency and you notice that they're breathing fast and you put them on the monitor, all right? And you happen to see this, okay? So I see a couple of different things there, some really good answers coming through the chat box. So a couple of people said DKA, diabetic ketoacidosis. Yeah, that's probably one of the more common ones that we think about would be DKA, diabetic ketoacidosis, where they are acidotic and they're breathing at that rate to blow off their CO2. When we talk about how the body maintains a balance between acid and bases, the fastest way it can compensate for that acidosis is to increase its respiratory rate. So this physiologic hyperventilation may actually be in response to an acidosis. A couple of other things here that we talked about include see somebody here says sepsis, someone else says panic attack. You can see somebody certainly having an anxiety attack who can be hyperventilating like this. I would caution you though, and just want to bring this up, that when we think about the anxiety portion of this, we should always assume that there is a physiologic reason or a pathologic process going on that's driving that anxiety. Okay, so anxiety, particularly guys, anxiety and hypoxia, it should equal imminent death to you. That's a person who's in shock until proven otherwise, and we got to figure out where that shock is coming from. That hyperventilation, anxiety, and someone who's having a low sat, that's a bad day. Sepsis, Dr. Barinholtz mentioned sepsis in the chat box. It's another great example. When people are septic, they are acidotic. As a result of the hypoperfusion from sepsis. And when that happens, they too can hyperventilate. In fact, our colleagues in Orange County, Florida, did a study years back where they took a look at septic patients and they put them all on end-tidal CO2 monitoring, and they were able to correlate that end-tidal CO2 in the low 20s correlates reasonably well to a lactic acid level that's higher than normal, indicating hypoperfusion. So this stuff can tell us, this information can tell us a lot about what the cells are doing and not doing. In fact, if you look at our Maryland sepsis protocol, we mention either a lactate level that's elevated or an end-tidal CO2 level, because we know that that can be a surrogate for a lactate level as well. It can give us an idea. All right, let's keep moving on here. So as mentioned earlier, I want to talk about the four main uses or so for capnography. It's very helpful for asthmatic patients, for the monitoring of the intubated head injury patients. We'll talk about it for cardiac arrest and of course for tube confirmation. So there's a very classic waveform that we may see in patients with some type of reactive airway disease, asthma or COPD, or even a partial airway obstruction, because physiologically that's what those diseases are. These patients have a difficult time exchanging gases, and the reason they have that difficult time exchanging gases is because they can't get air in because of the resistance in their airways. And so you get this shark fin appearance. It's pathopneumonic. That's a fancy word for meaning if you see this, it equals that. So a shark fin appearance should indicate to you there's some type of restrictive airway process going on. And in this case, we're using the asthma as the example here. And if you think about it, why is that? Because asthma is a disease of obstruction, of spasms and secretions and swelling. So they can get air in, but they're having a hard time blowing air out. And that shark fin that you see here is representing the resistance in the airway that they're blowing against to blow that CO2 out. So it's taking them, they're having to work almost the entire duty cycle of exhalation to blow that air out, okay? Let's see here now. Let's talk about the differences between a mild asthma attack, right? This person's got some shark fin appearance here, as you can see, and they're breathing fast because they're working hard to breathe, but their end-tidal CO2 is in the mid to high 20s, okay? This is a person who needs assistance, and we're going to give them a bronchodilator, and we're going to get, you know, steroids, and we're going to get them transported, maybe some supplemental O2 and all the things that we know to do. All right. Whereas the severe asthma attack may look something more like this. Okay. So now we have a person whose end-tidal C, or a moderate attack, we should say that you can see their end-tidal CO2 is creeping up higher. But what's concerning to me is their respiratory rate isn't. So why are they not breathing faster to blow off that CO2, which is what I would expect them to be doing. So it could be because they are tiring out or they're getting fatigued, which is one of the things that we worry about. Whereas in a severe asthma attack, you can see just how long that person is trying to blow to get that air out. And now their rate is really low. Their respiratory rate is 9. You can see their CO2 going higher and higher. So my takeaway message is this is a person who needs immediate intervention. This is a person who probably needs positive pressure ventilation via non-invasive ventilation. And if we don't do something soon, this is a person who's going to imminently go into respiratory arrest on us. So you see this, particularly with a slow rate and a high end-tidal CO2, it should make you want to request additional resources. It should make you want to expeditiously transport that patient and be prepared for them to crump on you. Okay, that's the biggest thing this does, is it gives us the ability to prognosticate how the patient is doing, but also to be ready for what's going to happen next. Okay. This is a person who's getting ready, who's headed towards respiratory arrest. And depending upon how bad they look in the clinical context, and they're probably getting sleepy at this point. These are the kinds of people, when we talk about giving epi in the protocols too, for an asthmatic, like giving IM epi for an asthmatic, these are really the people that we have in mind, or certainly before they get this severe, because we got to get moving on these patients. All right, let's move on to the next one. Let's talk about the head injured patient. So carbon dioxide, as I mentioned earlier on, as the product of metabolism, is also an acid in the body. And it actually has the ability to dilate the cerebral blood vessels and to increase the volume of blood in the intracranial vault, and can actually increase intracranial pressure. Now, I'm sure we've all heard or learned at one point in time about hyperventilating head injured patients and when to and when not to do it. Let me try to make it as clear as possible here. Okay, what we really want to do with the head injured person from a pre-hospital perspective is keep them at a normal end-tidal CO2 range. We don't want it too slow. We don't want to hyperventilate them off too much. Why? Because if we do, we're going to vasodilate them more, and that can actually worsen their intracranial pressure. So we want to keep them at levels around 35 to 40 to help minimize the chances of increased intracranial pressure. Okay, so there is a difference, guys, between titration and hyperventilation. When we talk about titrating someone's respiratory status, we want to keep them to that end-tidal of between 35 and 38, 35 to 40. So we want to ventilate them to that level. We don't want to hyperventilate them or hypoventilate them, but our goal is to target their ventilation. And this is, of course, for the head injured person who we are breathing for them, who they are now intubated. And it will really help us best manage and maintain them until we can get them to hopefully a tertiary care center, a trauma center, et cetera. What about the role for hyperventilation in head injured patients? Well, that's a separate lecture for a separate night, but I will say that the only time we should be hyperventilating the head injured person is when there's imminent signs of herniation. And that's all I'll say about that. But for the purposes of this lecture and for tonight, we really want to titrate our oxygenation and, our ventilation of these patients to those end-tidal CO2 numbers. All right, let's talk about end-tidal CO2 and cardiac arrest, because there's a good chance that that's where you may have seen this applied. And I want to just contextualize that and talk a little bit more about it. So One of the things I mentioned earlier on is that when we see a sudden rise in end-tidal CO2 during CPR, that may be an indicator that we're going to get return of spontaneous circulation. So let me be very clear. We're on a cardiac arrest. The patient is intubated, or the patient has a supraglottic airway in, and we're ventilating this patient. And we're minute 5, 7, 9 into the arrest. We've maybe gotten our first 1 or 2 EPIs on board, and we're working this arrest. And lo and behold, the end-tidal CO2 that was 18 now goes to 26 or 28 or 30. That's a person who we're going to get back. Now, one of the things we won't have time to talk about tonight is our post-arrest bundle of care. But that's someone, when we get that return of spontaneous circulation, we have to have our plans in place, and we have to be ready for what happens next. And that's the theme of everything that I teach and I talk about. Is it's managing the situation now, but being ready for what's next. And if you can do that in your practice as an EMS clinician, it will serve you well and your patients very well. So the unfortunate analog to my statement is also true, which is that end-tidal CO2 measurements during and throughout resuscitation that don't go up, in fact, that stay less than 10 after 25 minutes of CPR, are correlated with non-survivors. So it's very, very hard, if not impossible, to have an intact neurologic survival of someone in cardiac arrest who's had an end-tidal CO2 of less than 10 after 25 minutes of CPR. Why is that? Because their cells simply aren't making energy. Cellular death has occurred at that point, and it becomes very hard. Now, there may be other factors as to why we don't where we continue to resuscitate them. Again, not to get into that, but just from a clinical perspective, end-tidals less than 10 in a confirmed airway really are associated with non-survivors after 25 minutes of CPR. If you've never had end-tidal rise during the arrest, it makes me want to take another look with the laryngoscope if you have an ET tube in there to make sure that we're in the right spot and the tube hasn't popped out. Whereas survivors to cardiac arrest, those who've had survival to discharge, we tend to see that spike in end-tidal of greater than 30, and that may predict ROSC. Now, there's another phenomena that isn't on my slide I want to mention for a second, which is sometimes you will get to a cardiac arrest patient, the patient will be intubated or a supraglottic air will be placed, and the end-tidal will come back at 70. And we're like, woohoo, end-tidal 70, this is great. And then it goes down, 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 down. That person, the etiology of their arrest may have actually been some kind of hypercarbic respiratory failure that occurred. And that may have been contributing to their arrest. We can continue to work them, but if that end-tidal continues to go down, down, and we don't see that spike again, that too is not a great prognostic indicator. In fact, it's a bad one. So last we'll talk about here is this concept of tube verification for our ALS colleagues tuning in tonight. Remember that no waveform, we have to assume it means no tube, and we have to check further. All right, so end-tidal CO2 monitoring is the gold standard for airway confirmation. That if we see that, and if you watch the tube go through the cords, if you're an intubator, and now you have that end-tidal CO2 on, and you confirm that tube in place, as long as that waveform is consistent, you can be reassured that tube is in the right place. All right. Other than looking at a tube through the cords, there simply is no better way to verify the tube is in the right position. Now, there are cases where the tube could back out and be sitting at the very entrance to the vocal cords, at the very entrance of the glottic opening. That is certainly possible, which is why it's not just looking at it, but monitoring for any signs of changes. All right, for your intubated patients or your ventilated patients, if you do interfacility transport, I would certainly hope after hearing this lecture, you will make it your practice to always have them on end-tidal CO2 monitoring. Okay, but you don't have to wait for them to be intubated. Any severe respiratory patient that you have should have end-tidal CO2 monitoring going on. Okay, you can put it in line. You can put them on the nasal end-tidal CO2, which is a great thing to do. There's a strong push. Myself, my colleagues feel very strongly that if we're giving narcotics or sedatives in the field, for any reason, we should have them on end-tidal CO2 monitoring. You've seen that probably in messaging for those from Baltimore County tuning in. Dr. Pollack had some messaging about that not long ago. Dr. Chismar has put out some messaging at the state level about this. It really is quite important because it's going to be our clue as to how well this person is ventilating and are they getting too sleepy, and is that CO2 rising? Because as that CO2 rises, they're going to stop breathing. Okay, so 4 key uses of capnography. We talked about that characteristic shape of the capnogram for a COPD patient. We can also use this to help us prognosticate or determine how severe an asthma attack is for somebody, and to monitor and maintain ventilation at an adequate rate and volume for your head injured patients, and of course during CPR as well. So there are a couple other things as we wrap up the lecture here I want to just touch on very quickly. Troubleshooting. Let's say that you're BVMing a patient, okay, and you have the End-Tidal CO2 monitor on, all right, and you see waveform that looks something like this, okay, or you have an intubated patient and you see waveform that looks something like that. That makes us think about an air leak or a trouble with the seal, okay, and that could be happening, and you can see that very quick rise in CO2, but it doesn't, you don't see that plateau maintaining, and that should indicate that there may be some kind of equipment problem. There was a comment earlier on in the text box, the chat box, about obstruction. When we see airway obstructions, we tend to see something that looks more like a triangle or like a mountain peak, and that's because of the resistance pattern, both during inspiration and expiration, or inhalation and exhalation. And so you may see this erratic or kind of unusual appearance of a waveform. The problem, guys, is if you look at just the numbers, those numbers look fine, right? Those numbers don't look bad at all. But the waveform and the number gives us a tremendous amount of information. All right, let's see if I can keep moving here. Okay, there is another phenomena that's called rebreathing. And this is also something that happens with our asthmatic patients, where we see the fact that they don't actually get we don't actually get down to a 0 baseline. And that's because these people aren't able to fully get all that CO2 out of their lungs. And so we see this in our patients who retain CO2, and that rebreathing phenomena. If you have an asthmatic patient that's been intubated, that you're mask ventilating, you may see this as well. And sometimes what we'll do in these severe asthmatic patients, particularly if they're unconscious, is we'll actually put a little pressure on their chest momentarily just to help push some of that extra air out at the end of the inspiratory cycle or expiratory cycle. Question or comment in the chat box: what about bronchitis? Does it look similar to asthma? I would say it looks like SL put that in there. If we're talking about a COPD, chronic bronchitis, it certainly could. If we're talking about an acute bronchitis, with like an infectious process, it might as well. But the COPD, chronic bronchitis patients, where they've lost that elasticity of their lungs, of the alveoli, that's where we tend to kind of see that shark fin pattern. All right, as we wrap this up, let's go through some practice cases. All right, these are cases we've talked about throughout the lecture. Let's run through them real quick. So hypoventilation, as someone earlier on mentioned, is we tend to see this most commonly with our patients who have central nervous system depression for any number of reasons. This person is not only hypoventilating, but they're also hypercapnic as well. We can see their CO2 being up. So this is a person who needs some assistance, probably with some ventilation and oxygenation. But then we also want to try to find and fix the underlying problem. If it's an opioid overdose, this is someone who would be very appropriate to give naloxone. In fact, after you bring the patient to the hospital, after the overdose call, one of the things we will do is we will monitor patients on capnography, and we will use that to help drive our decision to give more naloxone. Because what we ultimately like to do in the hospital is titrate the naloxone to a normal respiratory effort and normal respiratory physiology. Okay, we mentioned this one a few moments ago. This is rebreathing or breath stacking, where the person is not fully able to empty out the CO2 in their lungs. And we talked about this, again, we see sometimes with asthmatics or with other patients who are retaining CO2. This is one I don't want you to forget. Please, this is one to remember, because if you look and you see this, even if you're not the highest ranking clinician in the back of the unit, if you look and see this, this is a problem, okay? This should be, you should have this burnt into your mind. This in the intubated patient is someone who we've just lost the airway on. Okay, this is someone who who the tube is no longer, whatever we are sampling, we're no longer able to get a reliable end-tidal CO2 waveform. So if you see this, particularly in this evolving or devolving pattern, that it should indicate to you that tube may not be in the right place, especially if they're intubated. That's a very concerning finding. We mentioned this one earlier on. This is the shark fin appearance that we tend to see with asthma. Question: are you seeing abnormal waveforms in difficulty breathing in the COVID patient? Awesome question. I'm going to get to that in a second. Okay, and of course, the last waveform here that we tend to see is this one. This one is the normal waveform that we hope to see. That is the one that's reliable. This nice, tight, square waveform with a normal rate, normal end-tidal CO2 measurement or capnography measurement there, capnograph number of 39 is a reassuring one. Okay, so I'm going to get to some questions here in a second. Capnography, in summary, gives us a real-time window inside the body as to how well that person is doing metabolically, how well their cells are able to not only produce carbon dioxide, but to offload it. It is, again, the gold standard for monitoring an invasive airway. It gives us a guidance for how fast or slow we should be ventilating someone. Remember, our targets for ventilation are between 35 and 40. And if that CO2 number goes up, we squeeze the bag faster. If the CO2 number goes down, we slow the bag down. We slow the squeezing down. And that will really help guide the therapeutic ventilation of that patient. It can also indicate a variety of different airway diseases and give us some indications to the prognosis of cardiac arrest. So with that, I thank you guys. Let me end my slide talk here and go back to the screen, and we'll take some questions. One of the questions that was in the chat box was, are we seeing abnormal waveforms and difficulty breathing with COVID patients? And the answer has to do with the underlying disease process. So someone with a COVID pneumonia, with a bad pneumonia, they tend to develop a pretty significant lung injury. And we can see both restrictive patterns, particularly if they're going into ARDS, but also, so the answer is you can see abnormal patterns with depending upon what type of pulmonary insult they're having. Looks like Dr. Barinholtz asked, can you comment on the limitations and absolute values if not intubated? Yeah, so that's a great question, Sean. How do we interpret this if we're putting someone on the nasal end-tidal CO2 monitoring? Let's say if they're not intubated, we're doing for non-invasive monitoring. It still provides a good deal of information. Certainly, normal is reassuring for us. But depending upon the clinical context, we can still use it to make informed decisions. I think about a DKA call I had a couple years back where this person was hyperglycemic on their labs, and then certainly we put them on the end-tidal CO2 via nasal cannula, and sure enough, they were breathing fast and their CO2 was low, and it made me think that they were in DKA. Let's see. Matt asked, so for BLS providers, what do you see for end-tidal CO2 for COVID patients with an O2 of 70, otherwise acting normally? Or Matt, I'm not sure I fully understand your question, but so when we have bad COVID pneumonia or patients have bad respiratory or pulmonary insults from COVID, it can take a major hit on the lungs, and these patients can end up going into a very, very challenging condition that's called ARDS, and basically the alveoli, they're no longer able to move very well at all, and there's a lot of secretions in their lungs. So it's both an onboarding of oxygen problem where they can't get the O2 in, and then they may not be able to get the O2 out as well. So the challenge there, Matt, is you're asking a very good question. It's actually pretty complicated to answer because depending upon how bad, and I'll turn it over to Dr. Barinholtz, feel free to jump in because I know you're a critical care physician as well. But if they're not able to get O2 in or out because of the alveoli being so bad, you may have a falsely reassuring reading on the end-tidal CO2. But typically we see other physiologic indicators that are going to tell us that person's pretty bad off. What would be?
I would add that, I think early in the phase, maybe when we see them as EMS, there's a lot of asymptomatic hypoxia going on, right? And we've heard from providers, that SAT can't be 75. They don't look distraught. They're wide awake. They're totally comfortable, right? Maybe some mild shortness of breath. But in those early stages, the end-tidal may actually look quite normal, right? And it's just really they're suffering from that early asymptomatic hypoxia that can rapidly de-escalate, unfortunately.
Yeah, they can deteriorate very quickly, and that's right. So if you see someone, you see someone with a SAT like that in the right clinical context, you should believe it. And trust me, no one is going to give you a hard time in the hospital if you show up saying, listen, this is what our SAT was. And you know what, you get there and the SAT is better. We're all going to breathe a sigh of relief. That's fine. We're happy to see that. We love that's not the problem. The problem would be is if we missed it and we said, oh, it's probably the pulse ox, whatever else. Rick asked in the chat box, what is the normal end-tidal CO2 you could expect to see someone with a COPD patient? Oh, good question, Rick. So COPDers tend to live at a higher level of CO2 levels in their system. So it might be slightly higher. You can see it in the 40s, in the low to mid 40s, but when we're seeing them, it's usually not because they're totally normal and totally fine. It's because they're having a problem. So if we see someone in respiratory distress, breathing faster, working harder to breathe, we should see that CO2 come back to a normal level. If their CO2s are remaining high and they're short of breath, then they're not able to offload the CO2 effectively. All right. What guys, feel free to come off. Nikki has a question. Can you show the form for the tube is in the wrong location again? Yes. I guess I shouldn't have ended my slideshow, but I can surely figure out a way to do that. Bear with me a second here, guys. While I do that, there was another question that came through. COVID pneumonia. Can I say something about that? Well, first of all, I certainly hope that your family member does okay. COVID pneumonia is a very complicated disease. Some people will do reasonably well with it. As Dr. Barinholtz had mentioned, it has to do with the degree of just how badly the lungs are affected by the infection. And so one of the things that a lot of folks are advocating for is if you have someone with COVID pneumonia is getting one of those, fingertip pulse oxes to keep an eye on them so you can monitor them closely. You can get them on Amazon, that kind of thing. They will hopefully give you some insight into how well someone's oxygenating. What would the CO2 look like in the end-tidal CO2 monitoring? Again, it's going to depend upon the stage of their infection. Early on, probably looking just fine. As they get, hopefully they don't get worse, but if they do get worse, we might expect to see abnormalities in the waveform and how well it's actually even able to sample if they're not able to get oxygen in or out of the system. And so it has to do with where that pneumonia can affect the patient. Let's see here. I think Nikki had asked for me to show the slide one more time of the of what it looks like when the tube is come out of the is no longer in the right place. Let me see if I can share my screen, and then we'll get back to some more questions. Let's see. Okay, can you guys see that now? Okay. So again, this is the waveform that we could expect to see when we have, let's see if I can draw here. So early, let's see here. I'm showing my inefficiencies. Okay, if you guys can maybe see my mouse, but this here is that normal waveform that we want to see. And then as it starts to go back down lower and lower and lower, that something is changing here. And what we have to assume is changing is that the sampling is that the sampling was working fine here. This equipment's working fine here, but something changed. So we have to assume that it's the inflow of CO2 that's changed. And with that inflow of CO2 that's changed into the system, that it's because the tube is in the wrong place. A couple more questions coming in through the chat box. There was an incident in Georgia today where the patient was exposed to toxic gases, and they've had and the question, I guess, here is have a normal capnography, but the patients are potentially ill or aiming towards extremis. Yeah, that's looks like I can't see who actually asked that question, but it looks like so that's a fantastic question. And earlier on, that's the part of the talk we didn't really get into too much, which is that this is telling us one piece of a story, but not the whole story. So you can have somebody who we pluck out of a house fire who's unconscious and unresponsive, and they can have either cyanide toxicity or carbon monoxide toxicity. Okay. And their CO2 is probably going to be a little bit elevated, to be honest with you, because they're probably going to be hypercarbic at some point. But the truth is that you can, you would expect early in the disease for it to look the same. Now, later on at the cellular level, as those toxins are blocking the cells from making energy, you're still going to have, you could argue you'll have lower levels or different levels of CO2 later on. And that's where a lot of different factors come into place. But early on in the immediate management in the field, you might see a relatively normal end-tidal CO2 with the patient, right? It's the same thing. Like you can imagine, I mean, the worst nightmare is us missing a carbon monoxide patient. Ironically enough, the treatment of 100% O2 is going to manage them anyway. But there are a couple of other conditions that we think about in critical care medicine that have to do with hemoglobin or it not working very well, or toxins affecting the hemoglobin. And you could, at least early on, see a normal, and when I say early on, I mean during the pre-hospital phase of care, a relatively normal end-tidal CO2. So really good questions. Other questions or comments that everybody has?
I think a lot of the questions that came up really help to, again, reemphasize, just as you said, Dr. Levy, at the beginning, that there are really too many different systems going on here, right? There's this whole oxygenation thing going on, and there's a ventilation thing going on. And they're oftentimes totally independent. Yes, sure, once the oxygenation continues to be bad and we experience respiratory distress and response, then that's going to start to impact our ventilation as we potentially get more ill. But yeah, a lot of these things, whether they be gases or an infection or COVID, that kind of stuff can impact oxygenation, but not necessarily see that early on with ventilation.
Yeah, that's absolutely correct. So as we add different types of insults to the body system or different disease processes, it can become harder to know what's normal for that person and what's the abnormal that we're seeing. So very well said, Dr. Barinholtz. Well, guys, that's a couple more questions here. Rob asked, so first of all, thank you all for tuning in. I know it's getting to be the top of the hour. If you have to go, I take no offense, by all means. But a couple questions still coming in the chat box. I'll do my best to answer them for the next few minutes. Rob asked, can I speak to using capnography to detect PEs or VQ mismatch or shunting? Well, a lot of information there, Rob. Good question. It will depend largely on the size of the PE and the degree to which that person is no longer able to make normal energy. So people can have a subsegmental PE where the other portions of their lung are working just fine, and you may not detect it. By the time a PE is so massive or submassive that we're seeing changes on the end-tidal CO2, we're probably also seeing other physiologic changes. So I wouldn't necessarily spend too much time or effort using the end-tidal CO2 at that point to try to figure out what is or isn't going on. I would focus on the resuscitation of that patient and the prompt transport. But it's a great question. There were a couple more that just came through that I will do my best to get to here. Let's see. CPAP and end-tidal CO2, can you use it? Yeah, you can. Absolutely. Now, depending upon the apparatus, the mask that you're using and the system that you're using, you may have some challenges. Some of the CPAP circuits will not fit the tube adapter for the end-tidal CO2 that you would hook up to an ET tube. Sometimes you can put them on nasal cannula, nasal end-tidal CO2, and then put the CPAP mask over top of them. But to be clear, if we are rolling or we are evolving into a positive pressure ventilation situation, at that point, what I want you to focus on is making an effective mask seal and ventilating that oxygenating that patient. Don't worry so much about the end-tidal CO2 at that point. In other words, if you're having trouble making the mask seal because the end-tidal CO2 nasally is on, that maybe don't let that compromise your ability to actually make a seal and get that patient oxygenated. A couple more questions coming through here. Thank you for the very positive and warm feedback, guys. Really appreciate it. It's been a hell of a pandemic, so it's nice to hear all the nice compliments. Let's see. Anything else coming through here I can address? I think I got everything. If I Someone mentioned out, don't forget that secretions can block side stream takeoffs. Yes, Shane, thank you very much for mentioning that. One of the challenges that we can see with the equipment, with the monitoring, is that if you've got someone with lots of secretions, blood, saliva, other secretions, they can block that port very easily. The other thing I would say that I think my pediatric colleagues would want me to emphasize is that there is, for really, really small kids, there is a separate pediatric End-Tidal CO2 sampling kit that used for little kids because of the amount of physiologic dead space in the circuit and the amount they're moving smaller volumes of air with their respiratory cycle. So I think I got all the questions. Dr. Bernholtz, I'll turn it back over to you for anything else I forgot to say.
Thank you. Yep, just amazing, great information, tons of great feedback and comments.